Dr. Brookmyer, thanks for joining us today.
Well, I'm glad to be here, and I'm glad to be 6 feet away from you.
Likewise. So could you give us a little background on COVID-19, how the virus originated, and what we're dealing with today here in Frederick County?
Okay, so I won't get into some of the conspiracy theories, but what I will say is, so early on we were calling it the novel coronavirus, so novel meaning it's new to humans. So when a virus is new to humans, that means our immune systems haven't already figured out what's the best way to fight it. And so we don't have pre-made immune fighting cells. So when the virus is initially detected in our bodies, it means that it's going to take some time for our immune systems to figure out how to effectively get rid of it. So we are more likely to suffer an infection then from it. And that's, if we think about already with, say, seasonal influenza, where the most common circulating strain is the H1N1, which was new back in 2009, but it's the most commonly circulating one right now. And if you think about how many of your coworkers and friends and family members were ill with the seasonal influenza, and that's after most of us have already been exposed to it, and we get vaccinated, and how many people that was. So now when you think about this novel coronavirus, which seems to be able to infect even more people more easily than the influenza, and it's something where we don't have the defenses already made, and we don't have an effective vaccine for it, it places us at greater risk. And that's why for public health, we've been so concerned about this.
So what are some of the signs and symptoms that a patient with COVID-19 would present with?
That is the difficult one, because the most common signs and symptoms are the same as for influenza. So fever, and so it's that fever where it's 100.4, but not everybody has a fever. Or at least at their initial presentation in the healthcare system, they also have not always had a fever. Shortness of breath is one where maybe it's a little more of a distinguishing feature from the typical influenza. But cough, some people have had some gastrointestinal nausea or diarrhea, but that's not as common. So really the most common ones are you have a fever and you have a cough.
So really what we know today, our staff should really treat anyone that they believe might have the flu as the possibility that they might have COVID-19.
I would say that would be a good approach. Now, if you would have asked me, well, and we did talk about this 2 months ago, I'd say no. At that point, we were still finding the cases were related to people who were direct travelers, or people had very close contact with those travelers who were ill. But now what we've seen over the last week, really, the last 2 weeks in Maryland, is that we've seen documentation and confirmation that people are becoming ill from what we call community transmission. So person to person, where the people, they have no idea who they came in contact with, when they came in contact with the virus. And when that happens, when there's community transmission, and when it's beyond just isolated pockets, then that makes it really difficult for all of us to tell. For sure, though, if someone has symptoms that are influenza-like illness symptoms, for sure now, those precautions should be taken as if somebody does have the novel coronavirus. I mean, we're still today, we have very high influenza activity, so it does make it difficult, but I would anticipate in the next week or two, for those people who have influenza-like illness, a much, much greater percent will actually have the novel coronavirus.
And that's really, that experience is what's been driving some of the changes in our 911 caller questioning, as well as our triaging of patients on the scene, where travel history used to be important, not really as important anymore. And we've modified our questioning from cough and fever to cough or fever.
Yeah, I think that's reasonable.
So today, and it's important for us to kind of time and date this conversation, so it's the afternoon of Friday, March the 20th. Let's talk about some of the things that are driving some of the division's decomp units, and how long do we know today, with what we know, does the virus live outside of the body?
Yes, well, and that is a question that a lot of people have had. And so I do have to say first that from the cases that have been reviewed, the primary or most common way that we believe people are becoming infected is through the respiratory transmission. So that's the coughing, sneezing, or spit talking. So it's good you're 6 feet away. And because they're respiratory droplets, they're relatively heavy and they fall to surfaces relatively quickly. They're not aerosols, so they tend to fall on surfaces. And then so it's that surface contamination. I do have to say, for surface contamination, like say this desk right here is contaminated. I'm next to it. I don't have to worry about it. It's not until I put my hand on it, now my hand's contaminated, but I still don't have to worry right now, as long as my hand doesn't touch something else, and as long as it definitely doesn't touch my face, until I can properly clean it. So that's first my spiel on the surface contamination. There's limited research that's available, and it's an area of active research. But from an article last week that was published in the Lancet Journal, they compared this coronavirus to the coronavirus that was related to SARS before, and they've compared it to some other viruses. So what's interesting is that depending upon what the material is, they were able to recover live virus for different durations. Oh, I also have to say early on, people did do research on, is there virus on various objects? So there's a difference between detecting RNA and detecting live virus. So the early articles were just, is there DNA indicating that there was contamination, but they don't know if it's live or not. So what was good about this research article, it was the first time that there's been a look at, well, when you recover it, can you also grow it in a lab? And so when they looked at stainless steel, the number of hours, maybe 48 hours, cardboard, maybe 24 hours. So it really varies by surface. Polypropylene, so some of the plastics, even longer.
One of the problems that I've seen and heard in the fire station is folks mixing up terminology. And that terminology confusion really exists around the words monitoring, if someone's monitoring their own health, isolation, and the words quarantine. So could you help guide us in the right direction of what's the difference between someone who's been directed to self-monitor versus someone who's been told to self-isolate or someone that's been told to quarantine?
Okay, yes. They are confusing and most often not used appropriately. The words are actually switched. So let's start with, the easiest place to start probably is if somebody receives a test result that confirms that they've had the novel coronavirus. That person would be advised to isolate oneself. And ideally, when somebody had the test performed, if the healthcare provider was so concerned that the person might have it, the healthcare provider should have already advised the individual that they should isolate and provide information. But so isolation refers to people who are sick and their movement. Quarantine refers to people who may have been exposed but do not yet show symptoms of an illness.
That's a great differentiator. So we always want folks to monitor their health.
Yes.
But we might put someone on quarantine if they were exposed but not yet showing symptoms.
Yes, and
And isolation would be that either they have a confirmed test or they've been directed by their healthcare provider that they're symptomatic and are awaiting test results.
Yes, yes. And I do also have to say, though, for the exposed, so we're still looking at close contact. So not every exposure really meets close contact. So we're 6 feet away. If you come down with it tomorrow, say you start having symptoms tomorrow, you know, I've kept my distance from you. So, and if I get out of here really soon, I probably haven't been here that long. So it's a matter of sort of the distance, what were you doing at the same time, and how long. So for close contacts, of someone who we think might have been infectious during the time that the person had close contact, then for that person, we'd advise quarantine. Now, if it was somebody who walked down the hallway when the person walked by, even if the person was thought to be infectious at the time, just walking down the hallway probably would not, lead to us saying, oh, you know what, you should quarantine yourself. That would be more of a monitoring.
Is there anything else you'd like to share regarding the COVID-19 response to our public safety responders?
Well, another really common question that I've received from employers, not quite every employer in Frederick, but many employers, is, well, what about if I live in a household with someone who works somewhere and someone at that person's place was diagnosed as having the novel coronavirus? So my answer is contacts of contacts who don't have symptoms don't need to worry.
That's outstanding information.
Yeah.
Well, folks, that's great information to update us on the current status of the coronavirus here in Frederick County. Thanks to Dr. Barbara Brookmyer from the Frederick County Health Department.